So what if Mrs. B had been really agitated, and now she's pulling out her IV, she's refusing to take her meds? What do you do? Because guaranteed you're going to get this phone call, probably within the first week of being in Jersey. What you gonna do? We really need to give her her meds. I can't get in there. We want to start that antibiotic. We want to treat her chest pain.
You sort of want to sedate her so she can receive the care she needs because she's just not in the right state of mind to make this decision. She doesn't want the meds.
Okay. And so what are the pros and cons of sedating a patient that's delirious? That's all. Are there concerns? Like, how would you approach it? Any ideas? Just get them asleep and get those meds in, and then we'll deal with it tomorrow. The Jersey on tomorrow. Get you with it. How do we do that? Anybody have any ideas? So we use Haldol. The current evidence is for Haldol. There is some people using atypical antipsychotics. This is a typical antipsychotic. And the only time we ever use this is really when they're a danger to themselves or others. Any other time you should not be writing this. This is not a PRN medication. This is the equivalent of, your patient's having chest pain. Can you please come see the patient, and you're giving the nitro or whatever. So your patient's delirious to the point that they're pulling out lines and they're dangerous. You need to go physically see that patient. You need to sit there and you need to be doing the Haldol bridge. It is not a PRN. It is not something you give over the phone. This is a patient who's really, really sick, and you need to go physically lay eyes on them, okay? So that's the only time you use it, because there's harm that can come from this. And we're balancing, you know, we can't manage them, and now they might be harming themselves or others with the harm of what we're about to do to them. So it's not something you just give lightly. So you only give it in severe delirium. The dosing is 0.5 to 1. Notice where the decimal is, because in ICU we're having a lot of debate about the amounts that we give, but it's 0.5 to 1. Especially in older adults who have never been on any of this medication before, you want to really start low. We give it IM or PO. We don't give it IV because it's short acting, goes in and comes out too quickly. We want to give it a little bit more longer acting. Now what you want to do is you want to give that medication, and then you're going to wait 30 to 60 minutes. 30 minutes if there's, like, you need, like, we've had 90-year-old little ladies with 4 security guards on them. Some of them can get severely, severely agitated. So if you've got someone that is agitated, then every 30 minutes you're probably going to have to be giving something. For the other person who's just really pulling out lines and you're trying to, you know, you can kind of talk them out of it if someone's sitting with them, but they're still pulling out their lines. You can go every 60 minutes. And what you're doing in that 30 to 60 minutes is you're going back through the chart and you're figuring out, are they delirious? What labs do I need to order? What could be happening? What do I need to be checking for? What can I start treatment? What can I do? What's causing this delirium? And what you want to do is you want to give it every 30 to 60 minutes till they're calm. Not comatose, just calm. And there's a big difference, right? So you don't want to just slam them and then they fall asleep, because you're going to risk a whole bunch of other stuff. So you want to do it till they're calm. Now whatever that dosage is, that's your loading dose. So it's important to know what that dose is. You don't really want to exceed 3 to 5 milligrams in a 24-hour period, that initial period, because really by then you fill up your receptors and you're just getting a bunch of side effects. Okay, so take your loading dose, and then what you want to do before you leave the room, so now they're calm, you've ordered your lab, you've started some management, and this is what you want to write before you leave the room, before you go back to bed or to see the next patient. You want to write a dosage of Haldol for the next 3 days. So we call it the Haldol bridge, because what we're doing is we're bridging them to safety. They're sick, there's something going on with them, we're going to start management, but just because you ordered that antibiotic doesn't mean the UTI is cured that immediate moment, right? So you need time, a couple days for everything to take effect. So what you're doing is you're keeping them safe until the medications work, until you figure out what is the cause. If by the second or third day they're still really, really bad and you're needing extra dosages, then you've missed something and you need to go back and look again. So that's your only sign that you're on the right track and that you haven't missed something. And because delirium is multiple things, right? You could have this and this and this. We've had people that we thought, okay, well, this and this is happening, we're treating this infection, and they had a retroperitoneal bleed, or, you didn't pick it up right away because that's not what the initial signs show. So what you need to do to kind of figure out how much to give over the next couple of days is you take whatever you gave to calm them down, which is your loading dose, you take half of that and give it in divided dosages the next day. So for ease of math, let's say it took you 3 milligrams to calm them down. What I'm writing the next day then, right away, is I'm going to take 1.5 and divide dosages, right? So 0.5 TID times 1 day, then 0.5 BID times 1 day, 0.5 OD times 1 day, then DC. So that should be written before you leave the room on that very first day that you're going in and giving the help. Does that make sense? This is a really important point. People keep missing this point, and it's a point that we're going to be creating a whole bunch of protocols and stuff for all the wards, because people remember now to use Haldol, but they're giving crazy amounts, they're giving it PRN, they're just ordering it willy-nilly. So this is really the way that it needs to be done. Haldol is not without risk, so you can't give it to patients with Parkinson's disease or Parkinsonian symptoms. It can cause tardive dyskinesia, and so people that have Parkinson's are already going to be at increased risk of that. They're very, very sensitive to any antipsychotics, so you can't give it to them. Never give it PRN, as I mentioned. And it can prolong the QT. So people will die from torsades, right? You'll prolong the QT and they'll torsade out. So you have to do a baseline ECG, which you should have done anyway because you're ruling out cardiac disease. If their QT is prolonged, then you have to look at some other medications. We can talk about that. Benzos can be other things, but we typically don't like to use those. And then the other challenging thing is, things like Cipro that we might give for a UTI also prolongs the QT. So you need to really be monitoring the QT every day on patients that you're doing this on, okay? So why is it important to treat the delirium itself? Why is it important to keep them down? So the mortality and morbidity associated with getting delirious in hospital is the same as if you had a heart attack in hospital, if you become septic in hospital. So we wouldn't leave patients septic, we wouldn't leave patients with having heart attacks. So therefore, we should leave patients that are delirious. And for a long time, people just said, well, that's normal after a hip surgery. Well, that's normal after, they're old. Of course, they're confused. But people just thought it was a dementia. So we left patients untreated with whatever it was that was causing this, and some died and some survived. And nobody really figured it out until, in the last 10, 15 years, where there was a lot of focus on picking this up. The reason that we miss it is, as I mentioned before, either not recognizing that delirium is important, but mostly now, I think people now recognize what delirium is. I hear everybody talking about it, but not recognizing the hypoactive. So the one that you get called about that you need to get the delirium or the Haldol for, everybody knows that patient. We're going to figure out, oh, they have delirium, and we're going to do the whole workup. The person who's quietly sitting there, who's not really doing physio, who people think might be depressed, they're not really eating, they're not really moving, they too have delirium, and they too have the same mortality and morbidity risk as the person that's fighting. It's just that that's how their body's manifesting it. So we have to really catch those people. And often people will fluctuate between the two. Any questions from the protocol or when to treat? So delirium is a sign that there's something going on with the body. You have to use your approach, it's more of a pan approach, partly somewhat from the history, somewhat from your labs, and then just having really high levels of suspicion based on their mix of symptoms. And you need to monitor this patient. Only use Haldol if they're a danger to themselves or others, because the risk is high with the prolonged QT and with the tardive dyskinesia. But if you have to get them on treatment, you need them to be safe, then you use it. Otherwise, you don't use it. You don't use it just because they're agitated, they're bugging the nurses a lot, but maybe we get a sitter, maybe we call the family, and maybe we do different things. That shouldn't be your default. Okay? And it's a Haldol bridge. It's not a one-time dose. It's a dosing over 4 days. Okay, those kind of some of the key points there.